Hello and welcome to this webinar for the Ask About Asthma week. This is the first day of the week and today we're focusing on parents and children and young people. Today's webinar we're aiming at parents, carers, children and young people, but also professionals as well, to help you respond to questions that you might be asked. So to encourage people to attend other webinars throughout the week and watch out for podcasts and blogs on social media. The main reason for the Ask About Asthma campaign is raising awareness of 3 simple measures that should be taken to manage all children and young people with asthma. You need a written asthma action plan, using inhalers effectively, and having an asthma review every year and after an attack. This will help ensure that children and young people can live their life alongside their asthma without their asthma interfering in their daily life and alleviating stress on the parents as well. And the campaign's also focusing on looking at the impact of air quality on lung health. Now I'd like to introduce the panel members we have here today. My name's Olivia. I'm a patient and public involvement lead in asthma research, and also I have severe asthma as well. So Julia.
Hello everyone, I'm Julia Moody. I'm a GP in Tower Hamlets in East London, and I'm the clinical lead for children and young people in Tower Hamlets, working with colleagues in the area.
Thank you. Jo, can I ask you?
I'm Jo. I'm a children's asthma nurse specialist working in Croydon with children and young people. I'm also the mum of a child with very difficult asthma.
And Richard?
Richard Isles. I'm a respiratory paediatrician working in South East London, and I have asthma.
And Jackie?
And I'm Jackie, and I work with Jo in the Croydon Community Children's Team, and I'm also an asthma sufferer.
It's fantastic. Welcome everyone. So we'll kick off with the first question that we have, and that was mainly sort of to do with parenting essentially, and it's sort of how can I explain to my child the importance of taking their medication? As a parent, I don't want to keep going on at them to take it because I know they won't, but I know how important it is because it can be dangerous if they don't take it. So who would like to answer? Richard?
Okay, I'll have first crack, and I'm sure others will add to this because I think it's really difficult. It's very, very difficult to explain something which is so episodic to small people, and let alone adults. So asthma is only there when it's a problem, really, to many people. So I think it's very, very difficult to actually explain severity and to most children and adults. I think it's really important to make this into a routine. So maybe those conversations don't keep coming into a crisis, so that if you make this like brushing your teeth, that you take your inhalers in the morning and the evening with the idea that actually you will be well and stay well as you continue to take your medicines. That's really a really good start. I think we've always tried to use more objective measurements such as peak flows, and there is a bit of peak flow variability that you can record when you're 6 and above, and then that gives a bit more kind of objective evidence as to how good or bad you are with the impacts of colds or any other triggers that might occur, which you can then use to kind of show to anybody, be that the child or a professional, that asthma is quite difficult to control, and it's not always that routine. So that's my first kind of thought. I'm going to throw it back to the rest of the panel to kind of add to that.
I wonder if now that we've had a sort of consultant's opinion, if Jackie or Jo, you want to input as a nurse, actually seeing patients in their own houses.
I mean, we use the symptom diary, so we give that to patients and parents to fill in, so that they can see. Usually we're sort of at the point where we're starting off a treatment, so the patient may be quite symptomatic with various triggers. Once they start using their preventer inhaler, they can see that the pattern of their symptoms improves. And so that's quite a good visual tool to teach the child that, yeah, before I took my preventer, I was having lots and lots of symptoms. Now I'm taking it every day. My symptoms have actually got better and I'm not using my blue inhaler.
And Julia or Joe, do you have anything to add, or are you?
I was just going to say that I think Jackie and I tend to do a lot of work in coming up with strategies for young people to be getting into good routines with their preventers. So it's about finding something that's going to work for them, that's realistic, and it's about it becoming autopilot for them, so that it's almost as automatic as brushing your teeth, having your breakfast, so that they can really nail it and get into that routine. And it is really just about unpicking their concerns, why they're worried about taking sort of daily treatment, and educating them about that. So I think it's just trying to be realistic that they may not remember it 100% of the time, but they do need to aim for that.
And I think I would just add that maybe it's an age appropriate thing. So I remember with my children who are also asthmatic, that using stickers and stars to reinforce it as you would with other parenting messages was a really helpful way at certain ages to help them get into the routine. And then there are different issues as they grow up, and there are different barriers to them taking their treatment. So really talking to them and asking them what matters and why it's difficult, sometimes really unlocked things that were complete surprises to me about why they didn't want to take their medication.
And if I could just add, I think it's trying to get those open conversations where you know, with the realistic expectation that people don't take this 100% of the time, but we're aiming for close to 100%. So there isn't a negative bit; it's a positive kind of reinforcement all the way along. You get so much shutdown when you get the negativity, and people just kind of move away from the kind of issues without those open conversations.
And so there was a lot of sort of mention of building routine there, and I think to build a routine there needs to be an understanding. And some of the questions that we get asked are, what does the preventer inhaler actually do, and why is it used? And also, why are spacer devices used as well? And I guess that comes into the sort of the long-term management of it, but having that understanding. So Julia, I wonder, you touched on that sort of understanding of medications and building the routines. Are you able to answer that question about what does the preventer inhaler do and its importance?
Yes, I try and start with children and families by explaining that we don't want asthma to stop them doing anything. We want them to sleep well, get to school normally, do every exercise that they want to do. And if they're not able to do that, that means we're not preventing their asthma adequately. And so the preventers are trying to do that. They're trying to make sure that they can live a normal life. And if we've got their treatment right, that should be possible. So it's starting from the position of expectation and building their people's expectation of what normal and what well-treated looks like. And then I use the management plans with families to explain to them what the different devices and medications do, because we all find it difficult to remember the names, and even the colours change from time to time. So if we have it clearly on the plan, and if we share that in effective ways, then I think we can have a conversation that builds on our shared understanding.
Joe, do you have anything to add from your perspective?
We have about an hour to spend with patients, so we're quite lucky in that respect, and I think that gives you the opportunity to really dig into how a preventer inhaler works, how it keeps asthma well controlled. We often use sort of visual aids to try and show the airway and you know, sort of which part of the lungs and the respiratory system become inflamed. So it's quite important, and that's for the parent as well, because often they haven't really sort of been told which inhaler they should be taking every day, and often are then relying on their rescue inhaler. So I think it's really about that education and having the time to sort of go through, this is what it does, this is how it works, this is what it's called. And often they haven't had that. So I think you can almost see the penny drop when you give them that information. And I think once they understand, then there's less fear and anxiety about sort of taking it every day.
Have a degree of anti-static, so that it's not perfect, but it's the best way to treat that kind of long-term inflammation. My visual for me is, when most people know what eczema is. Most people have seen children, or they themselves, particularly in the asthma world, where you have asthma, eczema, and hay fever together, you see eczema, and you know that eczema doesn't get better with just one slap of a steroid cream. And so asthma is like eczema on the lungs, but it takes that long-term coating to get the asthma down to a level which has much less, which doesn't trigger in response to a kind of external kind of, such as a virus or a pollen or something like that.
Jackie or Joe, do you have any sort of insights into the conversations you have with parents and children about the side effects of their medications?
We just very much talk about the low risk of using inhaled corticosteroids compared to the risk and unpleasantness of going into hospital with an acute attack. And often our parents, we get most of our referrals from the hospital, so the kids have been through that sort of scary episode, and don't want that to happen again. So they sort of do take the messages on board. But again, it's about the long-term picture and making sure that they keep up that good habit of taking their preventer inhaler.
So just to add that there are children who are on higher doses of steroids, and that should be covered at the asthma annual review or with a consultation with the consultant, whereby, yes, there might be some side effects, particularly around the kind of taking the medicine into the mouth with oral thrush, etc., or at very high dosages, you might see a theoretical drop in height velocity over a period of time. Now, for those children, the most important thing is to make sure that they do need those medicines, and then if they do need those medicines, to stay on those medicines. A small amount of height reduction compared to many courses of oral steroids is very, very insignificant. Okay, so when I first started looking after asthmatics many years ago, we regularly saw people who had failed to kind of reach, like 4, 5, 6 inches from their height, because of the only treatments were really oral steroids. And they were running into problems with their bones, etc. That is very, very, very rare these days. And it's probably because they may not have had any additive medicines which can reduce the steroid load if they have that degree of severe asthma. So I think one can't move away from the fact that some of these medicines at high dosage do carry side effects, but for the vast majority of children, they can be easily maintained on very small doses of inhaled steroids, so long as they take them as prescribed twice a day, every day, through a spacer.
And I want to add that a spacer device is very much sort of on the sort of at the forefront of asthma medication, but there are some inhalers that don't use a spacer device, such as the dry powder ones, because I know I recently saw someone asking a question about it was a parent asking a question about how do I fit this inhaler into the spacer device, and it was just confusion because they didn't have the understanding. So I think it's really important to highlight that it is only a certain type of inhaler that does go. It is the traditional, shall I say, spray inhaler that uses the spacer. and there are other types of inhalers. I think, Julia, you might see this quite a lot in general practices, all as parents with a sort of perhaps not understanding different inhalers, and sort of how do we get past that to ensure that there is that understanding?
Yes, I think we're not good enough yet at really sitting down with children, young people and their families and explaining the basics right at the beginning when they first have symptoms. And so I find that you're right, there are a lot of people who don't have a sufficiently good understanding of their treatment and how it works. And I think that's we need to make sure that a good quality annual review is available to all children and young people who have any treatment, whether or not they've actually had a diagnosis of asthma made. I think it's important that we're reviewing them effectively and making sure they understand the different treatments that we're using.
And the annual review is such a key part of asthma management just now, and I know myself as an asthma patient, I value my review, but it takes a lot of time to get the most out of your review. And often people don't understand that you need to prepare for the review. So it's sort of, what questions should the children and young people, but also the parents, be asking at these reviews to ensure that they get the best answers from the healthcare practitioner to allow them to have the best asthma control possible. So Joe or Jackie, do you have? So Joe, are you nodding there?
Yeah, I was just thinking back to when before I was a nurse and my daughter first started having sort of wheezy episodes. She was only 2, and we went along to see our practice nurse and was sort of given a salbutamol inhaler without a spacer, and then kind of left to get on with it. And then sort of over the next couple of years she was given sort of different inhalers, and I never really questioned kind of how they worked and what they did, because I was very much sort of, well, you know, you're the professional and this is your decision and this is what you want my child to have. And actually now when I look back, I sort of think, why didn't I sort of ask more questions? So I think it can be sometimes parents may feel a bit silly asking questions, or they may feel a bit intimidated. So I think it's really important for them to feel sort of comfortable to be able to say, okay, how does this new inhaler work? What do I need to do? How is it going to benefit my child? Just so that you've got all the information.
Richard, are you wanting to add something there?
Yeah, no, I love your idea that you need to be prepared for the review. I think that's so fundamental. So Joe and Jackie have been talking about kind of the symptom charts, about kind of peak flow diaries, things like that. Having it's meant to be an annual review, so having a review of the year and asking the healthcare professional, has it been a good year? Has it been a bad year? Could it have been better year? And sometimes events happen that don't necessarily trigger the attention of healthcare professionals. So a kid may have missed games or miss kind of school for a couple of days because they're not that well, but they don't need to see the doctor or whatever. Those things are still indicators of less than adequate control. So you don't need to be hitting the Richter scale of a hospital admission or a trip to A&E. Those are things that we should be prevented. Those are the things that are the red lights. We're trying to make the red lights now. An asthma attack needing a trip to hospital is a red light. An asthma attack needing admission is a double red light. We should really be kind of focusing on those kind of getting the kind of whole condition more stable on a day-to-day basis, which is really, really difficult because on a day-to-day basis, the things that trigger your asthma change. So it's a question of trying to follow this long-term condition on a daily basis, really.
Yeah, we would tell parents that if their child is using the blue inhaler 2 to 3 times a week, that's a red flag. they need to have a review, because that means that their asthma isn't well controlled. And that's what the annual review is about, looking at their salbutamol or their SABA use. How often are they using it? How often are they symptomatic? Does their treatment need titrated? And we find that sometimes this doesn't happen, that their treatment isn't moved up, and sometimes isn't moved down. And that's the really important thing of an asthma review. It's looking at the medication and in combination with their control of symptoms.
I love that idea again about preparedness and things that help us have the conversation. And one of the things we're looking at with children and young people is to see whether we can develop ways of keeping records of their symptoms that are easier. So we're using a smartphone app, and we're looking at additional devices that might help families and children just keep a sense of a record of how it's been, because you forget, don't you? And suddenly a long time's passed and you don't remember how it was before. So to keep a record on your phone might be a way of making those preparations easier.
Yeah.
I think it's one of the key things just now is having that preparation and knowing what's been going on for over the year, because you'll often only think about the last week or 2 weeks, because that's all you really remember. But having a diary of it on your phone or whatever is very helpful, because some of the questions have also been asked is, how do I know if the medication's been taken properly? Or my child refuses to take their medication in front of others and prefers to be laughed at because they're struggling. And it's things like these, often because they've happened in isolation, sometimes not in isolation, that by the time it comes around to the review, it gets forgotten about. So it's trying to provide tools for people so they've got answers to these sort of questions before they have to wait for the review to come round, because often it's not something that people think, oh, I need to see the GP about this because it's just a silly question. I want to provide these answers. So I wonder if Julia, as a parent, did you ever worry about if your child was taking their medication correctly, and how did you sort of address that?
Yes, I did worry about that. It's that difficult thing where you're trying to encourage independence as your child grows up, but you're also feeling and are responsible. And how do you balance that? And I think it's about trying to have those conversations openly. So sometimes I couldn't understand why my daughter particularly didn't want to use a spacer. And it was some time before she said, well, I don't feel like a sick person when I use my inhaler, but I feel like a sick person if I've got that spacer with me. And those conversations only happen over time. And it's so frustrating as a parent, because you can't always get in there to what the worry is. But I would say that also about the stigma that goes along with asthma. And I think the only way we really address that is through peer groups. So we're doing a lot of work in schools, trying to ensure that the whole school understands that asthma is a condition, and try to reduce that stigma. And particularly, I think, for adolescents, that's a big barrier to using treatment. So if we can have the conversations and understand the root of their difficulty, and then if we can include their community and their peer group, I think we might make some progress.
Jackie, are you wanting to?
Sorry, just trying to unmute myself. I think that there is those conversations to be had with the older children about the life-threatening nature of asthma, and certainly with the parents of the younger child. I mean, we have had children that have been, had those conversations happen in front of them and have been very, very scared and had nightmares and anxieties about it. But it isn't taken seriously, and it does need to be taken seriously. So
I think there's some things you can do in the background that maybe relate also to the last question that you asked, which was, one should not be using, or your child should not be using, one blue inhaler a month if their asthma was well controlled. On average, and you can work it out depending on the prescription for your child, one of the brown or preventer inhalers should be lasting about a month, and should be so you can put alerts into your phone to see, And most inhalers, not all, will have little counters on them. So you can do a kind of count thing, which is basically what people like me asking in clinics is, how much of your medicine have you been taking? And you can do those kind of soft patrols of how well your child is being adherent with their medicines at home before it all goes AWOL. So quite often we see kids in clinic who may not have taken their inhalers for about 2 or 3 months. That, if you had a kind of soft patrol looking to see when you last picked up a preventer medicine from the GP, because because it's empty, checking to see if it is half empty or wherever it should be, would be really nice to get, and feeding back to the annual review again. It's these kind of soft kind of things you can do at home, as well as the kind of symptom scores. I will say, as an asthmatic, I am pretty pants at taking my medicines as well. Okay, so I'm going to put my hand up there. It's taken quite a lot, and probably in my late 50s now, I'm just about getting it right, when I don't necessarily have the same pressures of work and kids and other things around me. So I'm going to be completely honest, when there are so many distractions, it is very difficult to actually get into this routine pattern. And I've actually got an app, and I've got a little buzzer on my inhaler now, which reminds me, to the point of being slightly irritating, to take my inhalers, okay, which I've found really, really helpful.
And I think, Richard, you've touched on something really key there, that everyone is human. We all have a very busy life, and we all have experience with asthma, whether it's we've got it or children have it, obviously, or we working in the field of it. And we know that no one's perfect. We don't expect you to come to clinics and be like, yes, I've taken my inhaler every single day, I've done my peak flow. But often as a patient, there is that we put that pressure on ourselves to say we are that perfect patient. But we all forget, whether we have very mild asthma or very severe asthma, there is days we forget. And as practitioners, we all know that not everyone's perfect. So as parents and children and young people, it's getting the majority of your treatment right. There is going to be mishaps when you forget it, but it's working that way to fit it in with your life as best as possible. And I think potentially as professionals, we can help alleviate that need to be perfect by owning up to our mistakes as well, and showing that patients that it's normal to forget.
Yeah.
I think, do you agree with that, or have any thoughts on that?
We're not perfect, are we? Nothing kind of comes ever is really perfect. It's very tricky, and I think it can put. I often see things going the wrong way when we strive for perfection. So, how do you actually distance kind of all the problems, and how do you prevent those kind of really open kind of conversations that Julia was talking about, where you add extra stresses and strains, and you add the asthma to your extra stresses and strains during the day. If you can get to where Jackie and Joe were saying, which is this kind of routine, so it becomes routine with those little kind of extra checks to make sure that the counters are going down or up, or whichever way they go on each device, the spacer is actually around and being used, and maybe you need to kind of do the symptom score at the end of the week, or you do the symptom or the peak flow once or twice a week, or once a month or something. Just being very readily available, all those tools that are there to help you, being very readily available and to be dipped in when you need them. You might need to kind of have a period of training every few months where you're doing them religiously for a week or two, but then you kind of dip into them and it becomes part of normal your routine world. This is a long-term condition. There are There are other children with long-term conditions such as diabetes who have to do their injections well, but they still face the same kind of adherence problems, that everybody gets bored, everybody gets kind of distracted. No one is actually perfect in this, but we must strive to kind of get that kind of routine perfection.
And also, I think it's, sorry, I just think it's important to take the fear out of the consultation. So I often, with our teenagers, I often say, look, I'm not going to tell you off, but I just need you to be honest with me about, because your symptoms are bad. So how are you taking your treatment? And then that leads on to those, you know, open conversations about why they're not, what's the problem? Are they embarrassed? Is it the inhaler device that they don't like? You know, the spacer use, that's obviously, that's a huge problem with our teenage population, because they're embarrassed to get out this big clunky thing. So, you know, it's just about having those, what are the problems? Tell us, let's try and fix them together.
And I think also, oh, sorry, I was just going to say about what you mentioned, Olivia, about being able to relate to patients. I think that's really, really important. And so often I think it's good to sort of show that you're human. So often I will sort of tell parents that I've got a child with asthma. And it's getting the fine line between sort of saying, well, this is what worked for me, and actually being able to get some common ground, because you find that if you can then say, well, I understand what you're going through because I've been through the same thing, often they relax and you can develop that rapport with them, and they feel that perhaps you're not judging them and sort of saying, well, you should be doing this and that. But actually, if you've been in that situation yourself, I think it can really sort of strengthen that rapport that you build with them.
One conversation I had with the late teenagers, and it's probably less impactful than it used to be when everybody wanted to drive and now lots of people aren't driving, was that when you are a late teenager, you probably want to drive a car or a moped, but you have to go through a test. And so you have to prove to people that you can actually do things properly before you kind of leave home, go to university, whatever else. And your mum, this is a conversation with the young teenager, your mum's got every right to be worried about you. She's worried about you for so many different kind of aspects. Why don't we take asthma off the list? Okay, why don't you just prove that you can do these things just for a period of time, so that you prove that you can pass your kind of asthma test, and then you can go out and about and do whatever you wish to do. Okay, so that was one kind of way of approaching some of the kind of. And there is a bit about teenagers, just to kind of share, having had 5 teenagers go through the house. I'm still here, but the concept that they are indestructible is very, very high in teenagers. Okay, you are made to be, you are at that time indestructible. So don't be. It's not unexpected that taking medicines at that period of time is a bit like Teflon. You don't need them. Why do you need them? All these kind of things will arise because actually it's not within the kind of normal, natural mindset of a teenager. If you've got a teenager who's taking their medicines, you are so blessed. You are so lucky. But teenagers are not meant to really be taking medicines and taking instructions.
Yeah, I think that's a big fear with parents, is it's the, if I give them the control, will they take that control? And it's getting the balance right of, and having the conversations about when do I give, like, hand over the reins, as it were, for asthma control. And I think that's a big fear with parents, and it's how do we overcome that fear? When is the right time to be doing this? And how do we sort of support parents to make those choices and make those decisions, but also support the children and young people to sort of embrace it and know the responsibility that they need.
So I think in there, one of the things is being a good role model as a parent. So not smoking, taking your medicines well. Okay, those are really good role models for the children. Why would a child take their medicines if if you are a parent with asthma and you don't take yours. There's some contrary kind of thoughts going through there, and messages, very mixed messages. You know, most kids are really genned up on the risk and problems of smoking. You know, so if you've got a child with asthma, really question, and the child will probably come back and question you, why are you still smoking? You know, when we know that kids live in this kind of world of less than 3 feet, and actually smoking really irritates the lungs. So those mixed messages, I don't think help in kind of trying to convince your child that they need to take medicines for asthma.
I was just going to say that I think it's really touching on what you said about sort of letting them grow up, letting them go, and handing over that care. I think is really, really difficult. And I mean, my daughter's 19 now, but when she was 16, she was very, very poorly with her asthma, and she's been sort of over the last few years developing skills in ordering her own medication and self-managing her asthma. And I think it's been really difficult for me to step back and let her do that. And I'm not sure if you found the same thing, Julia. It's, you want to keep controlling it, and you want to be the one that emails the GP surgery for the medication and have you got this, have you got that, and you're not actually doing that young person any favors, because they're then still relying on you. So I think it's tricky to sort of let go, but it can be done. I think it's a partnership between you and your child, that you gradually maybe hand over things step by step. But yeah, it's hard, and there's a lot of anxiety, I think, when you finally have to do that.
So I think this challenge just heightens all the normal challenges that we have in parenting, and it reminds me of another bit of work we're doing, looking at the rights that children and young people have to confidentiality within healthcare. And most children and young people want the support and benefit from the support of their parents and family members. But we should remember that as parents, we need to remember that they do have the right to autonomy. And from 13, they can access the NHS app and have access to their own medical records. And from 16, proxy access for children who have a normal development would be turned off automatically. And so I think as parents, it's hard for us to let go, but we need to be helping them to take responsibility. And probably that's the way to them having safer care, is for them genuinely to have to take responsibility and understand the consequences.
I think the worry never goes. My mum, I'm 36, and my mum still asks me if I've taken all my medication, and I get sort of a list of questions from her in a text message before I go to clinic to make from her. So I don't think the worry ever goes, but then the worry doesn't go at all being a parent, because I get questions about my health, but I also get things like, have you been eating enough fruit and vegetables? So it goes to the very basics of being a parent. It's not just to do with your health. So I think it's important that children, young people know that parents are always going to be parents and are always going to be wanting to make sure you're doing the right things, and it's not just parents nagging. So one of the other questions that comes up quite often, and there's a bit of mixed messages around it, is when do I give my child their blue inhaler, and how often do I give it, and how much do I give it, and sort of what symptoms am I looking for when to give it? Because I think there's always, we don't want to give too much medication, but we want to make sure we catch things in time. So it's giving parents the support to do that. So I think Joe or Jackie, do you want to answer that?
So we will always issue our patients with the personalised asthma action plan, and we encourage our hospital colleagues to do this as well as part of the discharge bundle. And that is the self-management tool, really, and guides parents and friends and other people that care for the children, their management guide around salbutamol use. So it's very, very clear. We always explain it and we encourage them to ask any questions they've got about it. And we also supply a copy for the school so that the schools use it. There's often a lot of anxiety around how schools manage asthma, but we kind of say, well, there are 3 children in every classroom with asthma. Schools are very used to dealing, you know, with asthma, and we do training sessions for the schools in Croydon as well. So, but yeah, that is the key. The PAP is the key.
Richard?
Yeah, can I just say that I think most people, like 90% of people, use their blue inhalers very sensibly according to the plan. One of the things that we have learned over the last few years is if you're using too much of the blue inhaler, something is wrong somewhere. Okay, and it's usually that your asthma is going out of control. There are a few children that kind of like to use their inhalers a bit, probably too much, but if you see that the number of blue inhalers is going up, then you should seek medical advice. And if that medical advice might need to go up to a specialist clinic, whereby trying to work out what is asthma and what is not asthma for a very, very few kids is really important. And trying to get those medicines back into kind of the really nice balance between very little blue inhaler and the right amount of the preventer inhaler. So I think that 99% of people stick to the plans, but moving away and within those plans are the instructions that if you are using too much blue inhaler, something somewhere is not working, and it's usually your asthma is going out of control, and being very, very aware of that.
And then there's a sort of common theory about asthma and allergies sort of go hand in hand, and then there is that sort of question about when do we give a child, when should EpiPens be used versus when should the reliever inhaler be used? Is it asthma, is it allergies, and how do we know sort of when we should be using what? You know, Julia, you might have some input on this.
Yes, I think everyone is very anxious, understandably, and we often get this question from teachers and schools about, you know, how should you respond? And I think the answer is that you will do no harm using an EpiPen if it's not needed, but a great deal of harm can come if you don't use it when it's needed. So I think people should have a low threshold for using an EpiPen if there's a sign of allergy, and for some children that will look very much the same as an asthma attack, and so difficulties breathing and distress and pallor, the symptoms of allergy and asthma can be similar. And at the same time, to also give the child 10 puffs of their salbutamol blue inhaler with a spacer, to stay with the child and phone 999 and call for an ambulance saying anaphylaxis, because that will get a very quick response from the ambulance service. So I think the message is, if you are concerned that a child's having an allergic or anaphylactic reaction, over-treat, over-respond, don't under-respond, and call for help.
Yeah. Absolutely. Yeah.
Are you wanting to add something, Richard?
Yes, I know, I absolutely agree. I think we have seen some tragedies happen when people haven't used the EpiPen in the right circumstances, which Julia described really, really well there. Just to reiterate that the airway is closing usually because of the allergy, and therefore if your airway is closing, the blue inhaler is not going to reach the parts that it needs to reach if you haven't given the EpiPen first. So the EpiPen will treat the airway closure from the inside, and then the puffer will treat it from the outside, but the puffer won't work if the airway is still closed. So EpiPen first, then the blue inhaler.
And I think leading on from that, because it is very difficult to tell sort of the difference, and it's what are the signs of a serious asthma attack? Because people will often refer to an asthma attack but give it so many different descriptions. I hear someone might say, oh, I've had 3 asthma attacks today, but Have they? Has it been they've taken their inhaler 3 times because they've been breathless? And there's a lot of confusion around that. So what, as professionals, would you say are the signs of a serious asthma attack? And sort of how would you sort of sum that up, as it were, from your point of view? What would you consider it to be? I don't know who wants to. Jackie, you're smiling.
No, I'm thinking that's a difficult question to answer. Again, going back to the asthma plans, there are the symptoms of asthma attack that needs emergency hospital treatment. But you could say that any symptoms are an asthma attack, because you have to take your symptoms seriously and use your blue inhaler appropriately. But obviously, shortness of breath, coughing, wheezing, chest tightness, not being able to eat, drink, do your normal activities of living, those are the red flag signs of a serious asthma attack that needs 10 puffs of salbutamol via a spacer and emergency care in the hospital. And that is very clear on the asthma plan. But even before that happens, you should be escalating the treatment. So very rarely do asthma attacks come out of the blue. You will have symptoms that are occurring in the days before, increasing, in severity. So get in early with your blue inhaler and seek a medical review before you get to that emergency point.
Well, I was just going to say what we tend to do is when we're going through the asthma plan, we kind of explain about what a child may look like if they're having an asthma attack. So I tend to advise parents that if they think their child is struggling to maybe if they're little or sort of school age, is to take their t-shirt off and really have a look at the chest. So what they then might see is the ribs poking out more than usual. They might see a bit of dipping at the base of the throat. Their nostrils might be flaring, or they may find that their tummy is more prominent than usual and they're breathing hard and fast. So I think you really, with sometimes it's really useful to go through what that might look like. Or it might be that their child becomes very quiet, or that they become quite lethargic. So obviously every child is different, but I think it's really good to sort of go back to basics and explain what they might actually see.
I think there's been a lot of mention about the action plan and the sort of personal action plan. And I think it's important that you can ask any one of your healthcare providers for one of these, and it's important that everyone has one. You don't have to go for an asthma review to sort of get one. You can ask your GP for one. You can ask if you're in the hospital for one. They're available in healthcare, as it were. Anyone can give you one and sort of put one together for you who knows you. And I think that's important to highlight, that you don't need to wait for your annual review to get one if you've not got one.
Absolutely, Olivia. And I think also if you haven't been given a formal diagnosis of asthma, you can still have a plan and still have something that helps you. Because I remember as a parent, even with a lot of experience medically, kind of that uncertainty about whether this child was unwell enough to go to hospital, whether it was, whether the child was unwell enough not to go to school. Those questions are really difficult. I have a 4-hour rule. So, if your asthma treatment, your blue inhaler isn't lasting for 4 hours, that's an emergency with asthma. That's a reason to be obviously increasing treatment and using 10 puffs if you need to. But if your normal 2 puffs of salbutamol don't last 4 hours, that's a reason for seeking help.
I think I'd like to just add that the importance of peak flows in people that can actually do the peak flows. So 6 and above, you should probably have a peak flow meter at home as well. If your child is so breathless they can't record a peak flow, that's really significant. Okay, so that is really, really worrying. But then it also gives you a kind of the numbers to communicate with either the A&E department or with your next clinic, that you have got, as we were saying earlier, the kind of evidence over a period of time of how good, bad or ugly your child was with their asthma attacks. Just because you don't end up in hospital does not necessarily mean to say it was a trivial asthma attack, and putting numbers with peak flows is often very helpful. When you run around and you get breathless, your peak flows will often go up. Okay, breathlessness is a normal thing for people like me, particularly when I do stairs. I will get breathless, and if I do my peak flows, because I'm using my chest better, they will go up. Okay, exercise induced asthma is a thing. It does exist. However, running around and getting breathless for the 99.9% of people is not asthma. And you can work out the difference by using a peak flow meter.
I think, Richard, you've touched on something there with sort of both running around and climbing stairs. It's often people ask, well, can my child still take part in sports? Because if you read a lot of sort of historical things, children were kept out of playing sports, but now with medications, children can very much still play sport, as long as they have that understanding of how their asthma and know their symptoms. And so how do we sort of, because parents will worry about a child playing sport. My mum still worries about me playing sport. It's natural in case it exacerbates an asthma attack. But what can we do to sort of alleviate that stress from a parent, so they can encourage their child to take part in sports, because it's part of a healthy lifestyle?
I think we underplay the peak flows for those people who sport is important, and when you go into schools actually. And I know there's this kind of fine balance between stigmatizing someone and not stigmatizing someone. But if we reach the point where you think that your asthma is really badly triggered by exercise, then you are probably in that zone already. I think our intention, our ideal, is to get everybody with asthma living a normal lifestyle, which is doing as much sport as they wish to do. So I think if there is a concern about sport, the currency that we often use for the older kids is the peak flow. So when you are feeling breathless, what is your peak flow doing? Okay, show me what your peak flow's done during the football match. Did you really need to come off at half time to take your salbutamol? Gosh, your peak flows did drop down. Oh, right. Okay. Well, let's maybe change your medicines in the background, recognizing that this is part of your long-term condition, rather than just giving some more salbutamol, which is what we don't necessarily want to do. So I think, yes, using that kind of methodology, we can get most people back to playing the sports that they want to play really quite easily.
Does anyone else want to input on that? Or?
No, that was a great summary. It reminded me as well of the crossover, which I know you haven't asked about, but it reminded me of the adolescents who we have an increasing population who have severe problems with anxiety. And in the same way as sport and asthma can be easy to confuse, anxiety and asthma can be really easy to confuse, and we can end up treating the wrong thing. So I think it's really important with both those groups that we really unpick what's going on and sit down with young people to try and understand it better.
Yeah. I would add to that, having a long-term condition which is poorly controlled adds to your anxiety, stigmatization, and mental health issues. Also, using too much salbutamol makes you anxious. It is a very close relative to adrenaline, which is your fight and flight hormone. So we often see this kind of really kind of mix of things going on at when people's asthma goes out of control, which might need quite significant specialist help with. So again, the more I start to think about this, more it comes down to I'm using too much salbutamol. Okay, I need to talk to someone. I need to talk to someone else, and then kind of unweaving whether this is asthma or whether this is anxiety or whether this is a problem with the breathing or anything else like that comes later down the pathway. But the entrance into that pathway is I'm using too much salbutamol.
I think one of the other questions that often gets asked is, will my child grow out of their asthma? Will they be on medication forever? Because there is these different theories that go around about children will outgrow it, there's a 7-year cycle. How do we unpick all that? Will a child grow out of it, or will they be on medication forever? Like, how would you answer that question to a parent?
It's a really tricky one. Everybody's expectation or hope is that yes, it will. If you come from a family of hardcore asthmatics, it's likely that you will continue to have asthma just like the rest of your family. If you have other kind of atopic conditions such as eczema and hay fever, then it's less likely, but it's still a possibility. If you have some of the food allergies, such as peanut allergy, etc., it's more likely to occur as a kind of long-term condition. And in reality, it's really tricky. It's, you know, I think again, I was taught that about 1/3 to maybe half of children outgrow their asthma. Outgrow is probably not the right phrase. It's asthma becomes less of a problem. My personal circumstances, I thought I'd outgrown my asthma like 10 years ago, got hit by a thunderstorm, and I was triggered very, very badly. So I think once you have the background, you are less likely to have, some people are less likely to have daily problems, but it should always be on your problem list somewhere. As you kind of move through life. So once an asthmatic, potentially always an asthmatic, always has the tendency or trend or potential to be an asthmatic again, if the diagnosis was made right in the first place.
I was just going to say that I agree with Richard on that front, because this is something that we get asked a lot, but I think it can, if you say, you know, your child may very well outgrow this, it does trivialize it a little bit. And so I think, you know, as Richard touched on, to have that awareness that it could pop up again at any time is better than sort of thinking, well, you know, when they're little, they're probably going to grow out of it as they get older, and we don't then therefore need to have a rescue inhaler at home. So we tend not to sort of say that when we're talking to parents.
I think that's brilliant advice, and as a GP, I often find asthma arising in people's 30s, and I had one this week of a woman who felt those familiar symptoms that she'd had as a child, and so was contacting for help, and she knew that she'd had asthma as a child, but I think in the past asthma wasn't as well diagnosed, and so we have a lot of adults who probably didn't have recognised asthma, but remember having difficulties with their breathing as children. So it's yes, once it's always there, and that's the benefit of our medical record system, is that it should always be there in the background.
And sorry, just to add, and this again is part of the annual review, and that's why it's really important that, you know, children or parents take their children to their annual review so that their symptoms can be looked at. And if they've had, you know, a symptom-free year, you're trying to get them back down to the lowest dose treatment that you can do.
I often explained it to people like it's a bit like a volcano, that it'll go dormant sometimes, but it could crop up at any time. We don't know when. So it's a sort of a visualization of it. Is how I've tried to explain it to people before, rather than it disappearing. It's sort of just simmering, not doing you any harm, but it could come back. If someone has had an asthma attack and they've needed to sort of seek medical advice, there's the advice to see your GP or nurse for within 48 hours of that sort of seeing someone who is it that makes that appointment, but also why is it important to be seen after you've had that attack, as a child or as the parent of a child? Why is it important to be seen afterwards?
So that statement appears in, is really core to most of our kind of health professional guidance. And it's there for one reason, and that is to make sure that everything is getting better or is better. The problem is that the systems don't necessarily join up. So ringing up Julia, I could ring up Julia and say, I want to be seen in 48 hours. And Julia's very nice person who runs her receptionist who runs her desk will actually have a complete epi at me, because that's going to be really hard to actually achieve. So I think the one thing is that it's to make sure that you're actually getting better, or you are better after whatever treatment that you've had. Can that happen in 48 hours? Occasionally it can. Sometimes it might be within 4 or 5 days. Again, coming back to the power of peak flows, one can see that the peak flows come back to normal. And if you are going to have an appointment with your healthcare professional in 4 or 5 days' time, showing the peak flow diary to resolution back to a normal level is about the most reassuring thing you can show over that period of time. Julia, I think I'm happy to hear your side of the story.
Yes, it's something we've been looking at really closely. We've sadly in North East London, we've had a number of adolescent deaths from asthma in recent years, and we've come together as a system to really look at what we can do to improve our care. There's a number of things we've done, but in Tower Hamlets, what we've done is establish a system where we automatically book everybody in for a 48-hour review. And I think the reason we've prioritised that is because we know that when we look at the population of people who do die from asthma, that a significant number of them have had an attack within the previous month, and that by reviewing them and making sure they're improving, we can reduce those risks. And it has been shown really clearly now that it also reduces the risk of subsequent admission. So we're still evaluating our version of this 48-hour review, but at the moment, I think for most people, I would say as parents, it currently is probably your responsibility to make sure that happens until we've got systems working more effectively so that they're booked in automatically.
And following on from that, Richard touched on that obviously sort of it's advised for the 48 hours, but often you'll speak to reception staff and they'll like, no, there's no appointments and things. How do you stress the importance of making that appointment? Because obviously there's sort of the reception is sort of the gatekeeper to the appointments in a way, but obviously they don't have that medical knowledge often and understand the seriousness of getting that appointment. So how do you get it across without obviously becoming grumpy and bullshit to the receptionist, but how do you get across that urgency and the need for that appointment?
So I would really hope that that's not everybody's experience, but I know that the appointments are short. So I certainly would hope that we would improve the sort of training we give to our staff. That's certainly something we're prioritising, so that receptionists know that asthma should be treated as an emergency. But I think as a parent, if you have been told that your child needs a review by another health professional, or you're concerned about their breathing, that you should ask to speak to the duty doctor if that's the only way of doing it. Every practice will have an emergency system, and if you're not getting the response you need, then I think it's fine to be assertive and say, I've been told that my child needs to have a review. As I say, we're trying to kind of make it an automatic assumption, but we're a long way off from that nationally, and so we've still got, we need, I think as parents, we need to advocate for our children and have the confidence to do that with knowing that it is what's recommended.
So can I just come back to Olivia, your analogy of the volcano, which I love, okay? The most likely time the volcano is going to erupt again is just after it's erupted. Okay, which is why we want to make sure that people are checked to make sure that they are actually getting better or are better from their asthma attack. If that cycle is not hit and controlled, then the volcano is just going to keep erupting and erupting, and potentially with more severity. So that's why we want to really make sure that people do get this follow-up after they've been in hospital, to make sure that their asthma is now, or their lungs are back and the peak flows are back and they are back to a good normal position.
I also think this is one of the benefits of the Ask About Asthma campaign, is that we can challenge one another, and professionally we can challenge one another to improve the quality of care we're providing. And that said, we're in a very difficult climate, so it's not an easy place to be in any part of the health service at the moment. But I think that we can challenge one another to prioritise, and I think asthma attacks have to be a priority.
And one could imagine that in our new world with virtual clinics, that if you had got a peak flow diary to show someone or something like that, it does not necessarily need to be a completely face-to-face clinic appointment. You know, if you've got the evidence that things have kind of gone in the right direction, that's brilliant.
Absolutely, Richard. And what's interesting is that we're finding that most of our 48-hour reviews don't need a face-to-face appointment. We're triaging them, and most of them can be done remotely, and that's quite appropriate and more convenient for many families. But it means that we can pick out the ones that do need either a face-to-face appointment or very occasionally to be sent straight back to A&E, as happened to one of our children last week. Because sometimes parents are learning and they haven't noticed that there's still a crisis happening.
Yeah.
I think one of the big things that we find just now is that often asthma attacks and uncontrolled asthma is actually being is occurring because of inhaler technique and sort of techniques not being reviewed, etc. And I think it was that less than 3 out of 4 young people don't actually get shown how to use their inhalers. And whose responsibility is it to make sure that you're shown how to use your inhaler correctly? Where can I find out about using an inhaler correctly if I'm not told by the GP, for example? Where do I go to get this information?
So as most of the prescriptions are coming from primary care, I think I have to put my hands up and say, if I'm prescribing something, that it's my responsibility to make sure someone knows how to use it. But I'm very fortunate that I work in a team. I work very closely with our practice nurses, who are very happy to see people and train people in how to use inhalers. But also we have community pharmacists, and we quite often, particularly when someone has an inhaler for the first time, we'll ask the pharmacist to remind the person how to use it and to go through it with the devices in the pharmacy before they leave. And there is a service that pharmacists are paid for, where that can be arranged. So I think we have to work as a team, and for all of us, we don't learn things on a one-off occasion, do we? We need reminding. So for all of us within the system, every time we particularly have a child with having an attack, it's an opportunity to train the child and the family in how they use them.
Jackie, have you got anything?
Yeah, so we train all our children and families in inhaler techniques, but we also back it up with links to Asthma UK or Right Breathe, because they have really good inhaler videos. So because we spend an hour or so with a parent, it can be a lot of information to take on, so we send them the links so they can relook at it and then send it to other people that look after the child, so everybody knows.
So a few years ago, in the medical world, there's a term called adherence, but we invented another word called contrivance. So people contrive to use their inhalers in a different way. So you might be told to use a spacer and an inhaler together, but well, why would you want to do that? I'll just use the spacer. But with every step down that contrivance pathway, you're getting less and less medicine. So it's really important that the people that are showing you how to use your inhalers actually are right up to speed with each of those different inhalers and how to take them properly, and to try and contrive how to use them differently is going to mean that they're going to be much less effective. So people naturally, especially the really imaginative people, will go off and do something completely bizarre with their inhalers. Okay, but they won't work very well. So it's really important to stick to the kind of guidance that is available from healthcare professionals, from the videos, from the right places. Okay, so Asthma UK have a selection of videos. I think other places have selection of videos, all of which are pretty sensible.
And I think one thing to add into that about sort of inhaler technique and using your inhaler and having your inhaler with you is that conversation about choice with the parent and the young person about what device is going to suit them best, because one device isn't going to fit everyone just because it's the one that's sort of considered the best of the time just now, but it might not suit their needs. And obviously there needs to be some what's the word, sort of give it is toing and froing, and you need to sort of compromise for the best treatment. But having that conversation and giving choice often I find will help patients use their inhalers better and actually use them in the right way.
Yeah. There is something that I'm quite worried about at the moment. There's a policy at the moment to move everyone because of greenhouse effect. We're still using CFC-free or not CFC-free inhalers, and there's still a greenhouse effect from most of our MDIs onto dry powders. Now, if your child is moved to a dry powder inhaler, it's absolutely essential that inhaler technique is checked to make sure that your child can use that dry powder inhaler. And if they can't, the default option is still a meter dose inhaler and a spacer. And just kind of worried that many people will be directed to dry powder inhalers for all the right global greenhouse emission reasons, but actually find that they can't use those inhalers as well as they could the meter dose inhaler and the spacer, which still remains the safe default option for most children.
Talking sort of moving on from sort of the greenhouse and sort of air effects side of things, one big thing as well for asthma is obviously the sort of pollution and air quality, because we know that air quality does affect asthma. And how can we, when we live in a city, how can we avoid this? How can we make our lives better? How can parents help make children's lives better and sort of improve the air quality around them? I know, Julia, this is something that you're quite interested in.
Yes, we worked with families in Tower Hamlets to develop some material to help them reduce the impacts of poor air quality, and it's been a fantastic piece of work, and I think it came up with many surprises for me. So, for instance, you're more exposed to pollution within a car than you are outside a car or next to it. In fact, you're half as likely to be exposed to pollution outside, and so walking and cycling and using transport that doesn't involve a vehicle reduces your exposure to pollution. There's also a very good app which you can have on your phone which alerts you to high pollution days, and also will allow you to plan routes to school or to wherever you're going which avoid pollution or at least reduce it. And so there are a number of things you can do to reduce it. And we also talked about the internal air quality as well. So as Richard mentioned about smoking, making sure that houses have low rates of pollution. There's lots that we can do. We can't eliminate it. We can also campaign, and I think we need to see some significant change in policy to reduce air pollution in our cities.
Jackie, do you find this is quite a hot topic with parents?
Yeah, definitely in Croydon. But the thing that I think is that parents and children have power within the school as well as the voice at the school. And so, you know, there's quite a few schools in Croydon that, you know, it's a no parking zone outside the school, no idling, that sort of thing. So increasing that is going to reduce the amount of pollution they're exposed to on their walks to and from and when they're in the playground. So, you know, parents and children have power too.
Yeah, I often find myself Googling postcodes, street addresses and things these days to actually find out where my difficult asthmatics live. So you're only 200 yards from one of our busiest kind of main roads in central London. Gosh, well, that's significant. Need to have a think about that, really. I think internal pollutants, we can get hung up on the external ones, which we can lobby against and kind of bring down. But looking at photos or doing a house visit and seeing mold around, really bad mold. Many of the houses, especially the lower income houses, are all bricked up so that they are warm, but actually that's a great area for mold to kind of grow, and really horrendous photos of black mold all over kids' bedrooms. Pets can be quite a good source of environmental triggers, and actually cooking. I think one of the data from that Julie may be referring to was kids, you could see the peaks when they were going to school, peaks when they came back from school, and then if they were sitting doing their homework in the kitchen where someone was frying the chips or fish or anything else, the pollutants went through the roof, many times higher than actually the pollutants on the way and back from school. So thinking about how you ventilate the house and remove the cooking kind of pollutants is probably quite important as well.
That's us out of time now. I'd just like to thank everyone for participating in the conversation today, and want to encourage everyone that there are more events happening for this Ask About Asthma campaign throughout the week. The link's going to be posted in the chat for you. So can I just thank Joe, Jackie, Richard and Julia for taking the time to speak to me today and answer the questions I've had and put to you all, and also thank everyone who's come to listen to us today and learn more about sort of asthma, the parents' perspective of asthma, and commonly asked questions. Any questions that have been put into the chat, they'll be posted in a frequently asked questions email bulletin that will be sent out to everyone who signed up for the event. So thank you.